today to host May Grand Rounds for the UBC Department of Emergency Medicine and welcome MIP Sekhon to talk to us about some pretty exciting stuff. I found out about the things that MIP was doing a few months ago and had a real pleasure about a month ago of sitting down with him and having a conversation. And he blew my mind with the stuff that he was telling me. It was absolutely incredible. So we're going to learn today about what he and his group are doing at VGH ICU, but not only about the state-of-the-art clinical care for brain injury, but the ramifications that it has for clinical care for all of us, and even beyond traumatic brain injury. And he's going to talk a little bit about that. So MIP comes with fantastic credentials. If you can imagine completing your primary residency, then completing your ICU training, and then deciding to go to Oxford and do another 2 years just in neurocritical care, and then bring this fantastic stuff back home. It's hats off to him for doing what he's doing, and probably one of the most knowledgeable guys in the actual management of patients with traumatic brain injury. So I'm going to hand it over to you, Mip, and thank you so much for coming and talking to us.
Appreciate it. I feel like with that introduction, I'm going to woefully disappoint, so I'll do my best. But is that working? Is that okay? Yeah. So first off, thank you very much. Thank you for the introduction, Jim, and thank you for the opportunity, and appreciate you guys coming out on a Wednesday morning to listen to me ramble for an hour or so. It won't be that long, but we'll certainly have some time for questions. So I'm going to talk to you about the updates of traumatic brain injury management. And specifically, I'm not going to focus on trials, and I'm not going to focus on p-values and Kaplan-Meier curves and so forth, but talk to you about actual patient physiology, the bedside individualized resuscitation that you deliver patients, and how to do that. And also talk to you specifically about that approach as it pertains to a functional, interdisciplinary and interdivisional programmatic type of care. So the neurocritical care program at VGH. I'd be remiss to not mention these two organizations for giving me some money for a fairly mediocre research career. All right, historical TBI management. This is not that long ago. 1960, this is what TBI care consisted of at Johns Hopkins. This is a gentleman in the recovery position to avoid aspiration. Here he's got a condom catheter on, he's got an oral airway, there's supplemental oxygen, and everybody cross their fingers and hope for the best. And this type of care actually didn't really evolve until the 1980s when certain things started to change. And so since then, there's been a tremendous amount of interest into pursuing, though, evidence-based medicine in traumatic brain injury. And unfortunately, trial after trial, whether it pertains to ICP monitoring, decompressive craniectomy, hypothermia, another trial of decompressive craniectomy, red cell transfusion, have repeatedly come up negative. And so there's been this notion in traumatic brain injury or brain injury as a whole that the injury that you have at the time of ictus is what you're left with. It is not modifiable. And I'm going to make the argument that it actually is. And unfortunately, I think we've suffered in a couple of respects from these trials and them being negative, mainly because we don't appreciate, and when I say we, I mean medicine as a whole, and I mean critical care, we are so stupid in the way that we approach this disease. If you think about traumatic brain injury is a syndrome. It's not a disease. It's a name that we have applied to an entity where there's blunt trauma to the brain that results in a GCS of 8 or less. And if I show you a few patients, like patient number 1, who has diffuse axonal injury, where the brain on CT scan appears structurally normal, but there's small hemorrhages throughout the brain. There's a rotational injury where the axons shake back and forth, and there's ruptures of the microvasculature that in the thalami, and the basal ganglia, and the corpus callosum, in critical areas of the brain, in the cortex, that result in a decreased level of consciousness. That gives you a GCS of less than 8. Patient number 2, where there's a subdural hemorrhage with midline shift, where the parenchyma is largely intact, that gives you a GCS of less than 8. And then there's patient number 3, where you have also intraparenchymal contusion, which gives you a GCS of less than 8. That's all traumatic brain injury. But those are actually different diseases, different natural histories, different physiologic consequences. But the failure that we've made is that we group these patients into large trials and we study them together. And unfortunately, we don't look at the underlying physiological characteristics because each 3 of these patients have different diseases. The only thing in common was a motor vehicle accident. Now, each of these patients, though, we do know their injury will be modifiable with the prevention of secondary injury, and I'm going to focus on that and describe what that is. So, I'm not going to talk to you a lot about evidence-based medicine. Like I said, I'm not going to show you Kaplan-Meier curves. I'm not going to show you p-values and all that sort of stuff. But instead, I'm going to, as one of my mentors in England used to say, you know, Mip, you should always focus on evidence-based medicine, but you should never forget about the medicine-based evidence. And that's the individualized resuscitation of your patient at the bedside, using physiological principles to optimize oxygen delivery, improve utilization, and prevent secondary injury. I'm going to start off with a case, though. So this is Jamie, permission to share. And at the time of her injury in 2015, she was a freestyle skier. And in fact, was en route, she was second in the world, ranked second in the world, and she was en route to attend the 2018 Winter Olympics in South Korea. Unfortunately, at the World Tour Finals in Whistler on April 5th, she suffered a fall in the half pipe. And so she was intubated on scene, and then she was helicoptered to our site. Her CT scan was associated with those dreaded words, diffuse axonal injury, an injury pattern which we have typically associated with a vegetative state. Her MRI, in fact, confirmed grade 3 diffuse axonal injury. So not only did she have small microhemorrhages throughout the cortex, through the deeper structures, the thalami, but also into the brainstem. And in fact, her examination confirmed that she was decerebrate posturing. And then she underwent a cardiac arrest on the hill. So here she is being transferred down. And this is her in our unit. Now, if we were to plug her characteristics into a large scoring system, the impact score, what we would find is that her chance of mortality was in excess of 60%, and her chance of an unfavorable outcome was in excess of 90% at 6 months. So keep that in mind. We're going to come back to that at the end. So I talked a little bit about secondary injury. Well, what is that? Secondary injury is the additive hypoxic or ischemic injury that is suffered by the patient from second 1 after the initial ictus to weeks thereafter. That is modifiable. You can't do anything about the fact that somebody went through a windshield or fell off their bike or was a ped struck, but you can prevent secondary injury. So those neurons which aren't dead, right, or which are stuttering along, they can be rescued, in fact. Now, our brain is only 2% of our body weight, but consumes 25% of our cardiac output because it is so metabolically active. And because it has no inherent energy stores, it is insanely susceptible to additional hypoxic injury. And if that's not corrected, or if secondary injury is not mitigated, well, that results in cell death, of course. And that is the cornerstone of TBI critical care management, okay? And in fact, yourselves have the biggest impact on that. Because, you know, we always talk about the golden hour of sepsis. But in fact, the golden hour of traumatic brain injury is probably equally as important. And the only reason that we don't harp on it is because the brain is so poorly studied. It's the hardest organ to access. This is the difference between normal brain and injured brain. So here on this is an electron microscope slide and of a patient. And here you've got a blood vessel here. You've got astrocyte end feet processes surrounded by neurons and axons over here. This is what happens after traumatic brain injury. This is secondary injury. There's vacuolization of those neurons. There's cytotoxic cerebral edema. There's perivascular cerebral edema. There's contraction of the blood vessel, all of which results in lower cerebral blood flow, lower oxygen delivery, and then an exacerbation of the injury on the right. Seen a different way in a cartoon figure, this is sort of kind of what it looks like. Here you've got a dendrite, you've got an axon, you've got oxygen molecules, you've got glucose, you've got astrocytes in their end feet processes. After an injury, There's microthrombi. The blood-brain barrier breaks down. There's neutrophil diapedesis. There's an inflammatory change. In fact, there's depletion of glucose, neuroglycopenia, brain hypoxia, which ultimately results in a reduction of oxidative phosphorylation, reduced ATP, and then cell death. So how do we prevent that? Well, it's kind of like a teeter-totter. There's the two sides to this. There's one, optimizing oxygen delivery, and the other one is optimizing oxygen utilization. I'm going to entirely focus on the oxygen delivery aspect of this because oxygen utilization is a totally separate topic in and of itself. So cerebral oxygen delivery is equivalent to cerebral blood flow multiplied by O2 content. The O2 content part of this is easy because that's predominantly determined by hemoglobin, but in fact the dissolved portion becomes very, very important after traumatic brain injury. Cerebral blood flow, we estimate with cerebral perfusion pressure, as you know, is MAP minus ICP. And ICP, there's a variety of determinants of intracranial pressure, one of which is venous return, 2, carbon dioxide, 3, temperature, and then 4, sodium. So I'm going to focus on all those physiological parameters for the remainder of this talk. And like I said, I'm not going to show you trials. PubMed is for that. But what I'm going to show you is individual patient files of the physiology changing in front of your eyes to sort of hammer home these points. So let's talk about intracranial pressure first. Intracranial pressure in and of itself, the absolute number is probably not that important, okay? We used to be hell-bent on reducing ICP to less than 20 in everybody. But in fact, it's probably individual dependent. And what's more important about ICP is not the absolute number, but where one lies on this spectrum of this curve, the compliance curve. So what you're actually doing with the intracranial pressure is you're trying to determine where your patient is along this curve. And here's a mass expanding a volume of a mass expanding lesion. So we're all sitting over here at a low volume and at a normal pressure. As compensatory mechanisms like venous return, like CSF shunting out of the intracranial space become exhausted, we start to escalate up this curve very quickly. And so this is limited compensatory reserve. The ventricles can only collapse so much, the veins can only collapse so much, and then shunt venous flow out of the brain. And then eventually you've got exhausted compensatory reserve, and this is where herniation occurs. So all the therapies that we're going to discuss coming up are all designed to drag a patient back down this curve and keep them sort of in this, what we think of as this healthy and safe place. Seen a different way, it sort of looks like this, where you've got 4 components of the intracranial volume. You've got the brain matter, arterial volume, which largely doesn't become changed apart from one physiologic phenomenon, which I'll show you later. But the CSF and the venous vasculature, those are the 2 compensatory mechanisms because they're low pressure compartments. So as a mass starts to take place, whether it be a tumor, epidural hematoma, subdural hematoma, intraparenchymal hematoma, cerebral edema, those 2 compartments accommodate up until a point where they can't do so anymore, and then one herniates. Well, let's talk about this again one more time. Oh, let me just go through this. I'm going to show you the importance of venous return. Now, venous return is critically important. Reason being, part of the reason it's so important is our CSF also gets reabsorbed into the superior sagittal sinus. That's how CSF exits the intracranial space predominantly. It gets reabsorbed in the superior sagittal sinus and then drains down into the sigmoid sinus and then into your internal jugular veins. So in fact, venous return not only drains the blood volume, but also the CSF volume. Positioning. We know that positioning is important. The question is how important? We know that, position, let me just touch on this for a sec. Positioning is so critically important, reason being the force of gravity takes venous blood back from the intracranial space and then takes it to the thoracic space and to the cardiovascular system. Now, so anything obstructing that flow will lead to venous engorgement, an increased venous volume, and then a subsequent potential intracranial hypertension, which can be catastrophic. So anything that obstructs that, whether they be endotracheal tube ties, C-collars, head of bed flat, high intrathoracic pressure from like a tension pneumo or high PEEP can be deleterious. So here's a real-life patient, and just to hammer home the points of how important, in fact, this is. So what you have here, we've got ICP on the x-axis, or pardon me, on the y-axis. We've got time in minutes on the y-axis or x-axis. So here's a patient trotting along, just perfectly fine at an ICP of 10. Patient was laid flat for an X-ray, and almost instantaneously, you can see the ICP shoot up to 20. And in fact, once the x-ray was over and the head of bed was back at 30, the ICP reduced by about 5 to 7 millimeters mercury of pressure. That is a lot. To put that into perspective, a decompressive craniectomy, in fact, only reduces ICP by about 8 to 10 millimeters mercury of pressure. Okay? It's a simple maneuver. It's cheap, if feasible, relatively easy to do. Here's another patient. Same thing. Patient's trotting along about an ICP of 10, head of bed flat for an x-ray, and then we put the head of bed back at 30, and then the ICP reduces to about 10. The other important thing here is this occurs within a minute or two. It's not like this takes time. It's not like this takes time for like a patient to go to the operating room, get an EVD for CSF diversion, which can take an hour or two. This occurs within minutes. And in fact, so highlighting the importance of positioning. In fact, here, this patient, now this is kind of an extreme example because this patient arrived to us with a hard collar and the face was somewhat purple, probably from it being on so tight. In fact, all we did was just loosen it to the point where you could get your fingers through. I'm not saying that C-collars aren't important. That's not what I'm saying at all. But in fact, they don't need to be strangulating somebody, probably. And in fact, here you can see C-collar removed and you buy yourself about 10 millimeters mercury of ICP change. How about carbon dioxide? Well, we know carbon dioxide, arterial carbon dioxide tension is critical. Reason being, hypocapnia leads to cerebral vasoconstriction and hypercapnia vasodilation. For every millimeter of carbon dioxide, arterial carbon dioxide tension is reduced by a millimeter, the cerebral blood flow drops off by about 2%. Okay? And vice versa, for every millimeter that goes above 40, it increases by about 2%. This is a real, this is our colleagues in Cambridge who did this study where they took patients with TBI, took them into a PET scanner, and then did cerebral blood flow and oxygen extraction studies on them. At normocapnia, hypercapnia, and hypocapnia. And what they found was patients exposed to hypocapnia, sustained hypocapnia for 20 to 30 minutes, in fact, dropped their cerebral blood flow by about 10%, dropped their, or increased their oxygen extraction by about 10%. Furthermore than that, the IBV is the ischemic brain volume. Patients exposed to a PaCO2 of less than 35 for 20 to 30 minutes, about 100 mils of their brain became ischemic. 10% of the brain became ischemic. And probably the most important 10%, the watershed areas, right? The thalami, the basal ganglia, the hippocampi. So very, very critical areas became ischemic, highlighting the importance of CO2 control. In fact, this is a real-life patient. This didn't project all that well, but here's one of our patients where we're monitoring end-tidal CO2, and this is in minutes over here. And what happened here is this patient was warmed at the same ventilation. We didn't change the minute ventilation. So the end-tidal CO2, in fact, went up only by about 5 to 10 millimeters mercury of pressure, but the ICP spiked to about 40. Then once we change the minute ventilation back down on the ventilator, end-tidal comes down and so does ICP. They in fact mirrored each other. So in this case, hypercapnia led to vasodilation, blood engorgement, and then increased ICP. Here's another case where similar sort of thing here. The ICP of this patient was about 30. Right? This is typically the level in which you would take a patient and take them to the operating room, do an EVD or decompressive craniectomy if they're on maximal therapy. All we did here was we ventilated the patient appropriately. And in fact, the ICP dropped from about low 30s down to about 15. And more importantly, occurred very, very quickly. So maintenance of normocapnia is critical. How about temperature? Well, we know for every degree of core body temperature that the brain increases, blood flow goes up by about 10%. And so in fact, in this patient, ICP about 20, 37.9, all we did here was cool them over 2 hours, and then the ICP gradually came down to about 20 or so, or 10. Same thing here, we lost control in this patient, 36.6, pretty good normothermic core body temperature control. Unfortunately, this patient became febrile, and then the ICP went up to about 20. Temperature changes generally take a little bit longer. Okay, so positioning, the changes with ICP with positioning occur very quickly. Similarly with CO2, but temperature changes do take a little bit longer to have an effect. I'm going to skip over that. The last thing I'm going to show you is another question I get a lot is, well, what do I do? Should I give the patient hypertonic or mannitol? To be honest, it doesn't really matter. The ICP reducing capabilities are the same. The one benefit of hypertonic saline is it's a slight volume expander, and in fact, it will augment cerebral blood flow by a little bit. And so what you have in this case is a patient, again, ICP about 30 or so, 150 mils of 5%, and within about 20 minutes, the ICP tapers off down to the low 20s. Similarly, in this patient, 5% given, the ICP comes down. More importantly, though, this is another catheter that we insert into the brain, which is an oxygen catheter. So it's a catheter that sits directly within the parenchyma and measures millimeters mercury of pressure of oxygen within the interstitium of the brain. It's our gold standard for oxygen delivery. And in fact, what you see here is ICP comes down, but in fact PbO2 comes up. So augmented oxygen delivery in this case. The one downside of mannitol, because of the post-osmotic diuresis, is you may get some reduction in cerebral blood flow. Hemoglobin concentration. Here's a patient. Typically the TRIC trial tells us we should transfuse patients, and I firmly believe unnecessary transfusions are bad. And the TRIC trial does tell us that in a non-bleeding patient, we should transfuse at a hemoglobin level of greater than 70. We do know in brain-injured patients, though, that additional anemia may, in fact, in animal studies, certainly does augment secondary injury. So in this patient, what you see here is, in fact, we transfuse the patient here. Here's PbO2. So to put this into context, 20 millimeters mercury of pressure means the brain is hypoxic. So this patient's hemoglobin was 75. We decided to transfuse the patient, and over the course of a few hours, the PbO2 gradually starts to come up. So these are changes that are occurring in real life, and you only see them if we actually look for them. And finally, the last thing I'm going to show you is, in fact, oxygen saturation. Now, the dissolved PO2 portion is such a small portion of oxygen delivery, as we sort of alluded to. However, it becomes critically important after brain injury, and probably has to do with that large diffusion barrier. I showed you that electron microscope slide where there's a lot of perivascular edema, and so that's critically, unfortunately, limits the amount of oxygen that can be offloaded by hemoglobin in the microvasculature. And so desaturations, in fact, pre-hospital hypoxia is the most predictive physiologic predictor of an adverse outcome. And so this is what happens. So here's a patient, SpO2 of about 100 or so. PbO2 is sky high. This patient is well oxygenated. Patient got a mucus plug. SpO2 down to about 82% transiently, but the oxygen, cerebral oxygen delivery fell off very, very quickly. I'm going to show you one last slide. SpO2 in this case, again, 98%. I'm not sure what happened in this patient. Went down to about 86 transiently, and the PbO2 mirrored that and fell off very, very quickly, highlighting the importance of adequate oxygenation. So I've showed you a bunch of physiological interventions. You might ask, well, what do I do with that, right? That's a bunch of stuff. I'm certainly admire your profession tremendously, because you're dealing with 8 million things at once, whereas that's certainly not the case with me. So we've got the time and the luxury of time to do that, or to optimize cerebral resuscitation. But how can you do this at the bedside? Well, we've recently come out with a checklist. It's a one-page checklist. And Jim's been tremendously supportive in getting this on the Emergency Medicine Health Network. And this is also supported by TSBC as well, to serve as a checklist for physicians in sort of maybe I'd describe a time-limited scenario to go through and just make sure that a few of those neuroprotective interventions which I was showing you are implemented, because it really is the golden hour of TBI. If there's additional hypoxic hit to the brain early on, that's what leads us to prolonged periods of cerebral edema, prolonged ICP monitoring, and all these sort of things. So this is, I think, soon will be available on the health network and also through TSBC. Okay, so that was like the nuts and bolts, but now I'm going to show you something different. I'm going to show you something unique, something that you won't see elsewhere, outside of probably Cambridge and a few other sites internationally. I touched on these three patients. And we touched on how they're different diseases. If you think about how we've traditionally managed TBI, is we've taken all patients, regardless of who you are, what type of injury you are, place an EVD or an ICP catheter and resuscitate everybody to an ICP of less than 20. Now, I would say that's fine, but it's a woeful oversimplification of this disease, because it doesn't take into consideration the individual variations that patients have, not only as individuals and their individual physiology, but also their underlying disease. The most important thing in preventing secondary injury is, in fact, optimizing oxygen delivery and blood flow. Well, is there a way that we can individualize that for that patient or for that disease? And in fact, there is. So I'm going to show you something here. This is personalized resuscitation. The question is, what's the optimal mean arterial pressure? Because even all of us in this room right now, I'm sure there's, like Nate, for example, healthy guy, blood pressure probably runs 100 on 60. I'm a moderately overweight Indian guy, probably run my blood pressure at 100 on 180, or 180 on 100. And so our brains are, in fact, used to different blood pressures at baseline. And so after an injury, why do we resuscitate everybody the same? It doesn't make sense. It's an oversimplification of the disease process. And so there is a way to target the optimal mean arterial pressure. And in fact, patients have individualized mean arterial pressures, and it gets to this sort of physiologic phenomenon called autoregulation, which you're all well aware of. If we plot cerebral blood flow on the y-axis and mean arterial pressure on the x-axis, in a healthy population, we maintain cerebral blood flow roughly between 50 and 150, a map of 50 and 150. Where below 50, there's pressure-passive vasodilation occurring. This is why we faint. The brain becomes hypoxic. We go into the recumbency position to augment blood flow. Above 150, this is where intracranial hemorrhage occurs, hypertensive encephalopathy, hemorrhagic transformation, hyperemia, right? So bad areas. Bad up there, and then ischemia down here. But we're all happy over here. And so our brain does this on our own. And the reason it does this, like I said, in the ischemic zone, there's pressure-passive vasodilation. For every increase of pressure, of mean arterial pressure, the blood vessels vasodilate. There's these L-type calcium channel receptors within the smooth muscle of the cerebral vasculature that wake up and say, whoa, 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 too much blood flow. They start to vasoconstrict. All right? When they start to vasoconstrict, the cerebral blood volume drops off within the preserved zone. And then there's that breaking point where they can't accommodate anymore. They can't take it. You undergo vasodilation. Question is, what happens after TBI? I was always taught that this was a direct straight line. Autoregulation is lost. And in fact, in most patients, it's not. And one other thing I should mention is ICP also changes within the zone of autoregulation. So in the ischemic zone here, pressure-passive vasodilation leads to an increased cerebral blood volume, hence the intracranial pressure goes up with it. And then, because of that cerebral vasoconstriction, which is appropriate, ICP comes down and then it goes up in the ischemic range again. After TBI, autoregulation is preserved in the majority of patients, but the window is narrowed. It's highly individual, it's dependent upon the underlying disease, and it changes from day to day. So if I were to draw the same ICP curve, what ends up happening in TBI is the same thing. In the ischemic zone, as MAP increases, ICP increases because of pressure-passive vasodilation. And then it decreases in the narrowed zone, and then it increases in the hyperemic zone. Now, if we derive a moving Pearson's correlation coefficient in real time, so it's only comparing fluctuations between ICP and MAP, you can figure out where this zone is. Now, follow me here. So, because it's a Pearson's correlation coefficient, it's only going to vary between +1 if there's a positive correlation between two variables, and then -1 if there's a negative correlation. So as the MAP increases here, the ICP increases, that's a positive correlation. Conversely, in the narrowed zone, as the MAP starts to increase in the narrowed zone, the ICP decreases, that's a negative correlation. So seen a different way, it sort of looks like that. That Pearson's correlation coefficient, positive in the ischemic zone, positive in the hyperemic zone, but negative in the preserved zone. That correlation coefficient, this is what our colleagues who worked the better part of the last 15 years in Cambridge discovering, they've termed that pressure reactivity index. Now if you plot the entire mean arterial pressure range against PRX, pressure reactivity index, +1 and then -1 down here, you get a U-shaped curve. So what ends up happening is something like that. And it's the nadir of that curve, which is that patient's optimal map. So it's sort of like Goldilocks. You don't want it too high, not too low, but just right. In fact, this is one of our patients. So you see here, I don't know if this projected all that well. This is roughly, this is a U-shaped curve. Here's PRX over here, +1 and -1. And we've roughly got a optimal cerebral perfusion pressure of 80 to 100. So this person's autoregulation curve kind of looks like that. Now the Brain Trauma Foundation guidelines suggest that we should keep everybody 50 to 70. Now if we were to do that in this patient would be critically ischemic. Additionally, here's a different patient. A little bit tighter range, CPP 90 to 100. Brain Trauma Foundation guidelines would say 50 to 70. This patient would be 20 millimeters mercury of pressure lower than the lower inflection point, so in the ischemic zone. Secondary injury will occur, and what we would say at the end of this is bad injury. This is it, real life at the bedside. So here's a young girl. Now, don't get me wrong. We're not indiscriminately pushing pressures. This is where I think the nuance of TBI sort of comes into play. Somebody's got big contusions. You're not going to push pressures in that case because there'd be significant risk of hemorrhagic transformation. But if they've got diffuse axonal injury where there's no real risk of hemorrhagic transformation, those are the patients that we end up eventually pushing quite high. So here's a young girl, diffuse cerebral edema after a car accident from diffuse axonal injury. Here's her CPP, and here's her ICP of 20. So she is 34 degrees, getting regular hypertonic saline, normocapic ventilation, sedated. She's sort of maxed out on therapy. The only thing's left for her, and the ventricles are slit-like, so she can't have an EVD. So the only thing left for her is a bihemispheric decompression. But in fact, all we did in this case was we looked at her monitoring, and in fact, her optimal CPP was much higher than one would typically expect, about 120. So the levofed dose here is 5 mics per minute. Didn't do really anything fancy, but increased it to 8. A few minutes later, 5 minutes later, the ICP comes down to 12 or 22. Not a big change, but once we get to a CPP of 120 again, the ICP comes down to 11. Right? So what's happening here? Over here, the brain is critically ischemic. It's releasing all sorts of endogenous vasodilators to augment blood flow. And all we do in this case is we augment blood flow by augmenting cerebral blood, or augment blood flow by augmenting MAP. And then the ICP dissipates within about 10 minutes. These changes occur very, very quickly. Here's an example of what it means with oxygen delivery. So here's the CPP right here in red, about 100 or so, far higher than the Brain Trauma Foundation guidelines would suggest that you go. Here's the PbO2. I said a PbO2 of 20 or so is where the brain is normoxic. What ended up happening here was, for some reason, the CPP fell off below 100. You can see how quickly the cerebral blood or the cerebral oxygen delivery falls off with it. This occurs within minutes. Conversely, over here, patient was hypoxic. We augmented blood flow. You'll notice here when you augment blood flow, the ICP comes down a little bit. That's that cerebral vascular vasoconstriction occurring. PRX, to make it easy for all of us who aren't colorblind, red is bad, green is good. Okay, you can see once we get back to the sweet spot, cerebral vasoconstriction occurs, it starts to turn green, and then the PbO2 flies up to above 20. So this is the epitome of individualized resuscitation. But you can only do this, unfortunately, with some additional monitoring catheters in place. Which brings me to like sort of the way that we've approached TBI. Like I said, I was saying earlier, TBI has traditionally been approached as a fixed disease. The ictus, the injury that you have, is dependent upon the initial injury at the scene. But this is all secondary injury, yet outcomes have started to get better. But the reason, and TBI, in fact, the clinical or the critical care sort of mantra of TBI is very similar to septic shock in terms of augmenting oxygen delivery, right? And we know that patients with septic shock, for example, who have oxygen delivery augmented and clear their lactates and have less organ failure, do better in the long term. Well, in fact, TBI is the same. The golden hour of sepsis certainly applies to the golden hour of TBI. But the way that you resuscitate, all of you resuscitate septic shock, not everybody gets the same amount of fluid. Not everybody gets the same dose of vasopressor. Some patients need dobutamine, some don't. But you individualize the resuscitation of those patients, right? This now, in neurocritical care, like I was saying, we're so dumb, we're finally catching up to the rest of medicine in terms of recognizing the individual variations in disease and physiology, and individualizing those the resuscitation of those patients. Now, I've showed you some interesting things. I'm just going to take a little sidetrack, and then I'm going to end off with something for you to think about. Now, I've showed you monitoring, and I've showed you physiology, I've showed you catheters. Okay? All that's fine, but unfortunately, this can't be done just haphazardly. You need a functional program. And so that's probably the most valuable thing that my colleague Don and I learned in Cambridge was the development of programmatic care for these patients. It's the nursing staff, to be honest, who need to be doing a lot of these cases per year, right? If you're only managing 4 to 5 of these cases per year or 10 of these cases per year, that's probably not enough to disseminate amongst the nursing staff in the unit and the RTs and the other physician staff. And so, in fact, you need numbers. You need constant education of the staff, pre-printed order sets, protocols. There's a tremendous amount of work that goes into this, but you also need buy-in. You need collaboration from neurosurgery, and so we're very fortunate to have that, and from our trauma surgery colleagues and from our emergency medicine colleagues, and of course buy-in from administration. So this is my good friend and colleague Don Grisdale, and I'm very proud to now note that in fact not only do we have a functional program, but it's the largest program in Canada by far. In fact, half of the cases of multimodal monitoring are done here in Vancouver for all of Canada. And we're not far off our colleagues in Cambridge. But we do a bunch of things. So this is the oxygen catheter that I showed you. We insert ICP catheters. We also insert this type of catheter, which is called a microdialysis catheter. Sits within the parenchyma of the brain and gives us crucial information as to what cerebral lactate is, cerebral pyruvate, glucose. If you want to measure phenytoin, you can measure phenytoin off of this. And then we have a blood flow catheter that measures cerebral blood flow in real time. So you can make critical changes to mean arterial pressure depending on what your blood flow is telling us. We, in fact, insert these catheters at the bedside. So here's Peter Gooderham, one of the neurosurgeons, and then Don, just at the bedside, placing the catheters in. And here's the patient right here. So we've got this 4-pronged bolt that sticks out of their head with all these catheters. And in fact, we've done most of these patients. I think administration likes this because we're saving operations and so saving the money. So most of these patients, in fact, have the catheters inserted at the bedside. It takes about half an hour or so. And we've very recently published these outcomes. So we noticed a few interesting differences. One of the things was because of these monitoring devices, in fact, our mean arterial pressure in our patients is much higher. We're using a lot more norepinephrine. Fortunately, in fact, troponin levels aren't different. No rates of cardiac arrest. Our atrial fibrillation rate is slightly higher, expectedly. Our temperature control is better, and our sodium control is better. All of this is programmatic care and individualizing the resuscitation of patients. And in fact, our duration of monitoring is less. So this is pre and post. So our monitoring free days are less. And this is probably because we're oxygenating the brain better. If you oxygenate the brain better, the cerebral edema dissipates. If the cerebral edema dissipates, you don't need to sedate patients as long. If you don't sedate patients as long, we don't ventilate patients as long. And then our ICU free days aren't quite significant, but certainly trend in the right direction. And most importantly, our outcomes are better. So pre was about 40% good outcome rate. Good outcome meaning back to independent life, full, like back to work, importantly paying taxes, or back to independent life but not back to school or back to work. But now we're about a 60% good outcome rate. Cambridge has about a 70% favorable outcome rate, so we still have some work to do to catch up to them. So coming back to that case, here's Jamie. We went through all her injury characteristics. So grade 3 diffuse axonal injury, decerebral posturing, pretty catastrophic. To be honest with you, I haven't been out working very long, but this is the patient that I can remember cases in training that we went to comfort care on. No question, for sure. There she was en route after her cardiac arrest, and unfavorable outcome rate of 91%. Here's Dawn putting in her monitoring. There's the catheters, one of the catheters sitting right there. This is the oxygen catheter sitting right in the white matter, frontal lobe white matter. And here's her monitoring. So you'll see here CPP of about 60 or so. Like I said, Brain Trauma Foundation guidelines would suggest we are doing awesome. CPP of 60, perfect. Look what the PbO2 is, though. PbO2 is about, less than 10. To put that into context, the PbO2 is 0 means no oxygen in the brain. That is brain death. And so all we do in this case is we augment blood flow a little bit. When we augment blood flow up to about a CPP of 80 or so, PbO2 comes up and the brain is normoxic. Most importantly, look how quickly this is happening within 5 minutes. So these changes are occurring so quick. Same thing here. CPP about 55. BTF would say good job. PbO2 here, though, was about 3 to 4. So over the course of 10 minutes, all we did was we augmented CPP. ICP comes down because of that compensatory vasoconstriction, and the PbO2 improves. So there she is, and then she came back to see us a year later. But it's not just her. I want to show you, and I have permission to share all these, a few patients just from this past year. But what you'll see is they're young person after young person after young person who typically, to be honest with you, I would have associated many of these young people with dismal outcome, vegetative states 6-7 years ago. And now it's just case after case are making really wonderful recoveries. And it's not secondary to the catheters, but it's secondary to a program of care between divisions, a collaborative effort, a multidisciplinary effort. Okay. Jim asked me to leave you with this. Perhaps in a few months, maybe next year sometime, I can come back and talk to you about some of the other things that we're doing. But if you think about, that's TBI. If you think about a similar disease pattern, let's take cardiac arrest, for example, right? 90% of the outcome in cardiac arrest patient survivors who survive the initial arrest get to ICU is determined by the inherent subsequent brain injury that occurs from withdrawal of care. Diffuse cerebral edema, hypoxic injury, gray-white loss, all that sort of stuff. So what if we approached hypoxic brain injury after cardiac arrest the same way that we approach traumatic brain injury? If we think about the parallels, they're actually not that different. If we think about how we manage TB, or HIBI, I should say, or hypoxic ischemic brain injury, it's pretty rudimentary still, right? You've got a patient who comes in post-cardiac arrest, and us as intensivists show up to the emergency department and just make asinine comments and suggestions. I fully believe that, to be honest with you. Because we show up and we say, oh, cool them to 33 or 36, doesn't really matter. Keep their map at whatever it is. And then we'll take them up to the ICU when we can get a bed, turn off their sedation at 24 hours. If they're not waking up, then we phone BC Transplant, right? Now, that's pretty crass, but it's not that far from what traditionally has happened. So what if we took the same approach to optimizing oxygen delivery in cardiac arrest, which is one of the things that we've started to do. So this is Don and I's major research program. So what it's a bit out there, I get it, but we're in fact characterizing the pathophysiology of this disease. Because there's no human studies to tell us what the optimal blood pressure is, what the optimal CO2 is, what the optimal sodium is, what the optimal temperature is. Even if you look at TTM, for example, awesome study, but there was no efficacy in both groups in terms of if temperature adequately achieved the therapeutic benefit of 36 versus 33 in terms of cerebral metabolism. Are they equivalent in terms of cerebral metabolism reduction, ICP reduction, seizure threshold reduction? So I'm going to show you a case of a patient which really changed the way that I think that we viewed the world. And this is Ashley. Again, permission to show. 31-year-old female, Wolff Parkinson White at baseline. No drugs at all. She's just followed by her cardiologist. She's never had a problem with it. She had palpitations, and that's how she was diagnosed. No history of cardiac death or sudden cardiac death in the family. She's a full-time student, single mom. And at 9 a.m., while in class, she underwent an arrest. A couple minutes later, her classmates recognized she was in cardiac arrest and started CPR. 10 minutes later, EMS arrived. She was defibrillated a bunch. Initial rhythm was VF, had epinephrine. And then 35 minutes later, they got ROSC. So post-resuscitation, GCS3, she arrives 12 minutes later at VGH. So she got very good management, I would say, on day one in the CCU. Pupils are 3 millimeters and reactive, sedated with just propofol and fentanyl. 36 degrees she was cooled to with surface cooling and very well. Her MAP was in the 70s, levofed roughly about 10. Her initial lactate was close to 8, so fairly significant ischemic hit. ECG was pretty unremarkable. In fact, she did get a cath immediately as she came in. The coronaries were clean, and in fact, her echo was largely normal. Here's her CT head on day one. Just run you through this. Cisterns are open. It doesn't project all that well, but you can see the sulci there. The sylvian fissures, the ventricles, probably for her age, are good. She's got some sulci up top, and gray-white differentiation is pretty darn good. I would look at that CT head, even though it's early, and say, oh, okay, we gotta can't really definitively say if there's a permanent bad damage. Okay, so day 2, sedation withdrawn, 30 hours post-arrest, and she's not doing anything initially. And then day 3, roughly 24 hours later, so 48 hours into this, our pupils are 8 and 8 and fixed. And in fact, we were asked to take over her care for organ donation. So one of my colleagues repeated her head scan, and cisterns, I think I can convince you the cisterns are gone. Can't see the intrapeduncular cistern, the quadrigeminal cisterns, but the gray-white differentiation still looks okay. And it seems to me there's a lot of cerebral edema there, right? The sulci are gone. So here's a 30-year-old girl, 48 hours into this, with that CT scan, and her pupils are fixed and dilated. So this particular colleague of mine, pretty aggressive, decided to get an MR right away. And here's a B1000 image. So white means cytotoxic cerebral edema. Okay, so she's got diffuse bilateral significant burden of cytotoxic edema in the white matter, in the corpus callosum, in the thalami, in the occipital lobes, the vision centers, Broca's area. Like, it's diffuse. It's bad. It's really bad. In fact, this is the diffusion weighted images, the DWI images, ADC map. Black or dark means that brain is on the verge of dying or dead. So again, bilateral, significant hypoxic burden, bilateral through this hemisphere. So with that MRI, fixed pupils, diffuse cerebral edema, and 48 hours post, seems like a pretty catastrophic outcome. So, in fact, this colleague of mine decided to give some mannitol and hypertonic saline. Pupils came down, then phoned us and said, "Can we put in catheters?" And I'll be totally honest with you. My first inclination was like, "No, I really don't think so. This sounds like a pretty bad outcome." but he's fairly persuasive. So we ended up giving it a shot. And this isn't a picture of Dawn putting it in her, but so we put the catheters in at the bedside. And just to highlight, there's the catheter. There's the PbO2 catheter right there. It's sitting directly within that cytotoxic and edema, or that brain tissue that was on the verge of dying or dead. So what we found was this. Her ICP expectedly was about 40. Her PbO2, way less than 10. In fact, down 2 or 3 millimeters mercury of pressure, so on the verge of that tissue being dead. And her PRX here, meaning that her autoregulation, she wasn't autoregulating at all. So it seemed like a significant burden of injury. In fact, her optimal CPP was quite high. So, the AHA says we should keep the MAP of 65 in all these people. And in fact, her CPP was upwards of about 90 or so. So we ended up pushing her with some norepinephrine. This is the day after. So here's the MAP right here, about 85 or so. The ICP has come down by magnitudes. She started to autoregulate again. Her PbO2 is about 25, so well oxygenated. Here's her repeat CT scan. Cisterns are open. She's got a little bit of the Sylvian fissure back. The gray-white is still pretty good, and she's got some sulci up top. No question, there's still edema there. So we went on and kept doing this for about 10 days or so. And day 3 to 5, so she's monitored with 5 days with this invasive monitoring. Sedation was weaned at day 6. She wasn't doing anything. So M1. Day 7, she starts to withdraw. Day 9, she starts to obey commands. 14, she's extubated. And then day 27, there's Ashley. So a girl who went from fixed pupils, diffuse cerebral edema, was transferred to us for organ donation, to be honest with you, who, with principles, there's no fancy therapies here included. There's no fancy medications. This is just principles of physiology, oxygen delivery, oxygen utilization. There's nothing more to it than that, to be honest with you. And so what we've started to do now is we've started to put in catheters into patients while studying them. So we're just about done that study, and perhaps sometime in the future I could come back and talk to you, because I'll tell you even the results for me characterizing this disease's physiology. I don't know how to look after these patients, to be honest with you. I don't know how to prognosticate them anymore. It's a disease that I think in medicine, myself, most guilty of all, have thought we understood, and we have no idea. No idea at all in terms of how to prognosticate these people or how to resuscitate them post ROSC. So anyways, food for thought. And with that, I'll take some questions. And I would like to give a shout out to, I've certainly been very lucky to come here and talk to you. But the real driver, to be honest with you, behind all this is my good friend, colleague, and mentor, Don Grisdale, who's the real champion of this program and has pushed it forward to what it's become. Thank you very much.
Questions?
Yes.
Just hit your button.
Now again.
Okay. All right. Thanks, Smith. That was really interesting. I just have a question. So this is all in the ICU where you guys are putting in bolts in people's brains. Do you have any recommendations in the emerge when these patients come into the emerge, and if you think we're doing things radically wrong? One of the things you mentioned is a lot of these patients seem to need higher MAPs than we've been targeting previously. Like, do you think we should be targeting higher MAPs in the emerge as well?
Yeah, that's a good question. There's a trial ongoing right now about this out of Belgium and Holland. They're randomizing patients to 85 versus 65. I still fundamentally think it doesn't make sense because what we're trying to do is we're trying to take patients and put them into boxes, right? Whereas the patients are so different. So one of the things that first off, I think you guys do a phenomenal job. To be frank with you, I think one of the things that we're trying to do in this study that we've just completed where we're putting in invasive catheters, we can get the optimal blood pressure and the optimal map in patients pretty quickly, within an hour or two. But we're also comparing it against non-invasive monitoring techniques as it pertains to cerebral oximetry, but also jugular venous oximetry. So hopefully that, I suspect it will give pretty useful information. I think that the notion is that patients, in fact, are unfortunately so different. They're not uniform. They're not the same. I think, personally, I think the map of 65 that the AHA recommends, the direct citation from that is the River study, where that recommendation comes from. I think it's too low, personally. So unless there's not another good reason, 75, 80 is what I typically do, and then tailor it with monitoring, personally. Yeah.
I have a question. So in cardiac arrest, the pathophys is essentially hypoxia. So would this not be also used for opioid overdose patients?
Yeah, that's a good question. So we've done a couple of those patients with opiate. So we just had a kid, 23-year-old kid last week. Same thing, fentanyl OD, but had a pulse, had diffuse cerebral edema. And in fact, when we put the catheters in him, the brain was critically lacking oxygen. In fact, in him, it was predominantly cerebral edema and high ICP. So he had a lot of like cytotoxic and vasogenic edema. So if you pushed pressure in that guy, he just augmented more cerebral edema. So in fact, we did the opposite. Kept his blood pressure very low and kept him cold.
Your call
like
will be
32 degrees
disconnected
for like 5 days. And he did great.